All right, welcome everyone to our live presentation. This is COVID-19 and FDMAS. Hosted by the Fibrous Dysplasia Foundation. My name is Tova, and I run community programs for the FDF, and I want to start by saying that everybody at the FDF, the board and the staff, we've all been thinking about the community, our patients and caregivers and advocates, and hoping we can do anything we can to offer comfort and be a resource to the community. We're so pleased. We know that this has been a difficult time for everybody, even though those challenges might look different for each of us. And we're so pleased today to be able to offer this, and hopefully this is offer some answers and some comfort. We're so grateful to be joined today by 4 of our medical experts and advisors, and also a 5th caller who's going to help us with translation. You know, we're really so grateful for these folks. They are so giving of their time, not just during this webinar and this season, really all the time behind the scenes, and we're very lucky to have their generosity, and grateful for them today for sharing their expertise during this discussion. So without further ado, I will introduce our guests. We have Dr. Alison Boyce, who's an associate research physician in the skeletal disorders and mineral homeostasis section of the National Institute of Dental and Craniofacial Research at the NIH. She's also our Medical Advisory Council Chair. Her colleague, Dr. Michael Collins, who's Senior Investigator in the Skeletal Disorders and Mineral Homeostasis section of the NIDCR, as well as the Director of Career Development and Research Training for the NIH Inter-Institute Endocrine Training Program. And he served as FDF's Medical Advisory Chair for over a decade, continues to be a close advisor of the foundations, and together he and Alison run the NIH's Natural History Study of FDMAS. And then we have, calling in from the West Coast, Dr. Ed Hsiao, an Associate Professor of Endocrinology and Metabolism in the University of California, San Francisco's Metabolic Bone Clinic, as well as the Director of UCSF's Diabetes Endocrinology and Metabolism Fellowship Program. And in Florida, Dr. Stanton, an orthopedic surgeon with Nemours Children's Hospital, Orlando, and a longtime advisor and collaborator with the FDF, and also the recipient of this past year's Constellation Award. And then we also are joined by Karen Pozo, who is a nurse who works alongside Dr. Collins and Dr. Boyce, and she'll be helping us with a little bit of translation throughout our presentation. And before I turn it over, I'll say that you can ask questions in the comment box on our Facebook stream, and we'll try to get to as many questions as we can, and you know, really focusing on questions that relate specifically to COVID-19 and this crisis. We thought we would start today's discussion by just talking about how each of the different institutions that each of you work for is responding to this crisis. So with that, maybe we'll start with Dr. Collins and Dr. Boyce. Do you mind leading us off and talking about the NIH's response?
Thanks, Tova, for having us. Glad to be here to try and help in any way that I can.
Being done. And similarly, outpatient routine follow-ups are being curtailed as much as possible. And if patients can be seen and evaluated by telehealth, we've expanded our telehealth visits by over 1,000% in 2 weeks. So I imagine that's going to continue long after the COVID-19 crisis is over. We've been perhaps a little bit late doing that because the payers wouldn't pay us for seeing it. They said they will. So I think that nationwide, we're going to see a big increase in that.
How about you, Ed?
So at UCSF, We still remain open. We're primarily seeing urgent and emergent cases in the hospital and related to things like surgery or non-elective procedures. Elective procedures are pretty much delayed for now. On the outpatient side, our metabolic bone clinic remains open. We've transitioned pretty much everybody to telemedicine or telehealth tools. And we have not seen much of a decrease in our volume from that standpoint. So we're continuing to help care for all patients with metabolic bone diseases, including TMAS. I think the main things that are slightly delayed are if any patients need bisphosphonates or infusions. In those situations, we have to try to schedule them and reschedule them depending on urgency.
Thank you. And Karen, can we take a moment and allow you to do some translation?
Sure. Buenas tardes, yo soy Karen Pozo, hablando sobre los Institutos Nacionales de Salud de Dr. Collins y la doctora Boyce. Parece que los estudios ahorita no estamos recaudando pacientes. También estamos teniendo esos estudios ahorita, no estamos aceptando pacientes porque estamos más enfocándonos en pacientes emergentes solos. Y pues, como mencionó la doctora Boyce, que solo los pacientes que ahorita estamos recibiendo solo son pacientes que son de emergencia. También la doctora Boyce menciona que tenemos estudios ahorita en los Institutos Nacionales de Salud sobre el coronavirus y estamos participando en eso también. Y pues vamos a esperar resultados de eso, ojalá que sean buenos. En el doctor Stanton dice que algunas de las cirugías han parado. Dr. Stanton, can you clarify, did you say that most of your surgeries have been put on hold for now?
Yeah, all elective surgery is done.
Okay. Como mencionó el doctor Stanton, dice cirugías, todas las que son electivas han sido paradas por este momento. In California, Dr. Ed, did you say that most of your bisphosphonates infusions are a little bit on hold for now?
They're a little bit delayed. They're being adjusted based on need and urgency. But our outpatient clinic continues to see patients using telehealth.
El doctor Ed menciona que la clínica todavía está viendo algunos pacientes también por computadoras, por teléfono, están viendo pacientes, algunas de las infusiones de bisfonatos, creo que se dice en español, todavía pacientes están recibiendo eso, pero hay alguna espera pequeña. I think for now that summarizes most of what we just said.
Thank you. Our live stream has been interrupted for a second here, so before we go to the next section, I am going to try to get us back up and running. We did hear, maybe miss the last 5 seconds of what Karen said, but okay, so now we'll turn our attention to this current health crisis. in our recommendations for patients. And I know there are some recommendations that are good for the general health and well-being of the public, but also how do those recommendations relate specifically to the FD-MAS community? Dr. Collins, would you like to start us off?
Yeah, I think probably all of us have been getting some communications from our patients with questions, and I can just share one or two of them. And Dr. Stanton and I shared a very interesting situation, which he can talk about. But I guess the biggest question that I've had from several patients is there any reason why FD-MAS patients would be more prone to becoming infected with COVID? And I think what underlies that is the question of, is there anything about the immune system of patients with FD-MAS that would make them more susceptible to becoming infected? And I think the answer is no. What I should also say too, and we talked about this amongst ourselves beforehand though, is we are in a phase where we are rapidly learning about this virus and this infection and this issue, and none of us can say very many things very definitively. So everything that I'm going to say is qualified in that, it could change tomorrow or the next week. But anyway, as far as I know, I don't know of any reason why patients with FD-MAS should be more prone or susceptible to becoming infected with.
And Karen, this is important stuff, so I want to make sure we really take time for it for the Spanish community. Do you mind translating for us?
Sí, claro, y si tienen preguntas sobre lo que digo, por favor, también pueden preguntar. Just to clarify, if what I didn't say wasn't clear, I just reminded the audience that they could ask just in case later on, if it wasn't fully clear. Okay, el doctor Collins dice que sí ha recibido preguntas de diferentes pacientes con displasia fibrosa, y estas preguntas están con el punto del tipo de riesgo que uno tiene con COVID-19, sobre el sistema inmuno, si estos pacientes tienen más riesgo que una persona normal. Y eso significa, él piensa que no, pero es muy importante saber que todos estamos aprendiendo. No estamos definitivamente seguros de esto, porque esto es un proceso que estamos aprendiendo.
All right, great, thank you. I'm not sure who would like to chime in here, and we can keep going around. Alison, do you want to add anything?
Yeah, no, I just want to reiterate that I agree with Dr. Collins. As far as we know, having a bone disease like fibrous dysplasia or having endocrine complications of McCune-Albright syndrome shouldn't put patients either at higher risk for contracting the virus or for having a severe course if they do contract the virus. One possible exception, which I think would apply to only a very, very small population of the FD community, would be if patients have very severe deformities of their ribs that have led to lung problems. And I think those patients would know who they are. I mean, if you have a primary lung problem that related to fibrous dysplasia, it's not something that you would discover just as part of this pandemic. It'd be something that you would already have complications from. So I think on the whole, our community can really view themselves as similar to the general population related to their risk. But of course, there's a lot we don't know about this virus. So that's kind of where we stand right now.
La doctora Boyce menciona que también está de acuerdo con el doctor Collins. Ella piensa que la displasia fibrosa o el síndrome de McCune-Albright syndrome también no hay un riesgo más alto que otras personas, con la excepción de pacientes que tienen deformidades en las costillas. Pero porque eso pudiera afectar los pulmones, pero normalmente si este paciente tiene deformidades en las costillas y problemas con los pulmones, eso significaría que este paciente ya estuviera que estuviera alerta de de este riesgo. Eso es lo que dijo.
Excellent.
As far as the bone disease goes, obviously our patients are not any real orthopedic implications from the COVID virus, but of course our patients are prone to lots of fractures, and if you have a fracture, you would probably go to the same place where you usually go when you have pain and you suspect a fracture. You get an image made, and someone will tell you whether they think it's fractured or not. If it's deformed, you would need to go to the place where you normally get your orthopedic care. If it's non-deformed and someone puts a splint on it, try to stay away from major medical centers in big cities, because I think they're going to be filled with COVID patients, and you'll increase your risk for picking up the virus if you go to places that are currently being taxed with lots of COVID patients. Many of the small fractures that FD patients get are non-displaced and can be adequately managed with a few weeks of splinting. You really need to go to a major medical center if it can be avoided.
El doctor Stanton repite que los pacientes con problemas con ortopédicos no están también en alto riesgo de tener este virus. Si tiene dolor o sospecha fractura, vaya al lugar que normalmente recibe el cuidado. Él también sugiere que sería buena idea de evitar ciudades grandes, porque estos hospitales van a estar muy llenos. What was the last part, Dr. Stanton? The part again about the fractures.
If you have a physical deformity with your fracture, obviously you're going to have to receive emergency care from an ortho center that's capable of taking care of that. But if it's a non-displaced fracture and you can avoid going major.
Okay. Si una fractura, pero no es una fractura severa que no ha sido completamente desplaciada, trate de evitar hospitales grandes y busque otro tipo de cuidado para que no vaya a un hospital.
I think one other, I think a critical point in all of this is that if anything occurs, you should keep in touch with your clinical team. If you have an upper respiratory infection or symptoms of an upper respiratory infection, it's still more likely that it's going to be some other respiratory type of illness, but you should still be evaluated for the COVID-19 virus. The best way to do that is to reach out to your primary care physician and your team to make sure that it's evaluated appropriately.
El doctor Ed menciona que es muy importante estar en comunicación con los doctores de ustedes locales, hablar con sus doctores sobre los diferentes síntomas. No hay una gran posibilidad que si uno tiene síntomas respiratorios, no es una gran posibilidad que es COVID-19. COVID-19, el coronavirus. Pero es muy importante estar en comunicación con sus médicos.
The other thing is that, as Dr. Stanton mentioned, in many situations, any sort of symptoms or potential new pain or potential fracture can be first evaluated using telemedicine. And so you should follow up with your providers to see whether that is an option.
Un buen paso sería que si un paciente se siente con dolor, tiene diferentes síntomas, el primer paso fuera comunicarse con sus doctores, posiblemente por teléfono o por videollamada, para evaluar lo que está pasando. Primer paso.
And then finally, probably the most important aspect is to try to minimize the risks of exposure to the coronavirus. And the best way to do this is to follow the social distancing guidelines and avoiding exposure whenever possible.
Un punto muy importante es tratar de seguir estas guías que estamos recibiendo de distancia social, de evitar lugares grandes con muchas personas y tratar pues de seguir estas guías que hemos recibido.
The single most important thing that you can do is to wash your hands frequently or to use hand sanitizer if that's not possible.
Es muy importante siempre recordarnos de lavarnos las manos frecuentemente o también el sanitador de manos, ese gel con alcohol.
So, sorry, unless, Ed, did you have anything else to add before I transition to questions?
No, I think from the standpoint of prevention, the main things to watch out for are washing hands frequently, avoiding touching the face as much as possible, and avoiding sick contacts, whether or not it's coronavirus or something else.
Puntos muy importantes, como hemos dicho, es seguirnos lavando las manos frecuentemente, por favor no tocarse la cara mucho y evitar contactos que quizás pueden estar en riesgo o puedan tener el virus.
So first I want to recognize that we have been having a little bit of trouble with our live stream, and I apologize for that. Please stick with us. I will continue to reconnect us, and the video will be saved in total to share afterwards. And we do apologize for the interruptions. We are going to turn our attention to our patient questions. And if you'd like to add more questions, please do so in the comment stream of our most recent video. Many of the questions have been answered addressing the relative risk factors of those with FDMS, but there's also a lot of questions about medications. So I'll start with our first one. This question is about ibuprofen and naproxen, which they've heard they should avoid. And they're wondering about prescription anti-inflammatories and what they should do about that.
I'll repeat the question too. Hemos recibido una pregunta sobre ibuprofen y naproxen y otras medicinas antiinflamatorias y cómo eso puede estar afectando.
So, who wants to take this? So, the word got out based on, in my opinion, very weak evidence that ibuprofen may not be safe in a COVID infection. I'm not sure what the official stance of the various organizations are, but my reading of the what literature is about this is that probably ibuprofen and drugs like naproxen and prescription anti-inflammatories like Celecox or Celebrex, I think are probably safe, but I would really like to hear what my colleagues think about that.
Sorry, go ahead.
Okay, thanks. Dr. Collins dice que la información sobre el ibuprofen con el riesgo del virus, dice la evidencia no es grande, que hay riesgos con este tipo de medicina con el coronavirus, pero vamos a discutir con el resto de del equipo aquí.
So the original report that originated all of this was actually a brief letter in a medical journal that speculated that ibuprofen and nonsteroidals could increase the co-receptor for coronavirus. They had very little data to suggest that, except other studies that had indicated that those genes could be increased if a patient were to take ibuprofen. However, there is no clinical data that we know of to date that suggests that ibuprofen or any of the other non-steroidal pain medications changes risk to coronavirus. So the data supporting that conclusion is relatively weak. The FDA posted an announcement about a week ago that basically recommended that no changes be made to medication regimens at this time until additional data has been gathered. What we have been doing at the UCSF clinic is that for patients who could be using other types of medications, we're assisting them with transitions. So for example, if a patient is using low doses of ibuprofen and they can manage their pain using acetaminophen, we help with those types of transitions. But if a patient has been getting excellent relief from a non-steroidal, such as celecoxib, then we discuss that continuing the medication for now is probably okay. It's important to separate the non-steroidals, which are anti-inflammatory medications, which are used for pain management, because these are very different from immunosuppressive medications, such as prednisone or steroids that might be used in other situations. And in those situations, the immunosuppressant medications, such as steroids, could increase the risk of contracting viral infections.
Okay, I'll try to summarize that as best as I can. El reporte que originó estas preguntas sobre el ibuprofen fue una carta. No hay información clínica que de verdad es fuerte, no hay evidencia clínica muy fuerte sobre estos cambios que pueden causar riesgo en el coronavirus. El FDA, que es el Departamento de Medicinas aquí en Estados Unidos, no ha recomendado cambios de medicina. Hay recomendaciones que es mejor si pueden usar para pacientes con dolor con el acetaminofén, para pacientes con dolor si pueden evitar el ibuprofen. Doctor, could you repeat about the anti-steroidal recommendations that you were making?
Yes, so for patients who would feel more comfortable and are on low doses of non-steroidal medications like ibuprofen, they can discuss with their doctor about transitioning to something like acetaminophen.
El doctor estaba recomendando que si hay pacientes que están recibiendo medicinas como el ibuprofen, que son medicinas que son anti-inflamatorias, es una buena idea hablar con sus doctores como recibir medicinas en vez de ibuprofen como la medicina de acetaminofén.
But if they are currently on an non-steroidal medication and have excellent pain control, there's no immediate need to switch.
Pero si el paciente está con una medicina que no esteroides, que no tiene esteroides, así como el ibuprofen, y están recibiendo buen alivio de su dolor, no hay una inmediata necesidad de cambiar a otra medicina.
So another medication question, this about bisphosphonates, which I think Ed touched on briefly. Are there more precautions that we should take? You know, they know dental hygiene is important. Is there other precautions they should take when receiving bisphosphonates?
Sí, hay otras precauciones que los pacientes deben de estar alertas cuando recibiendo bisfonatos.
Tova, did you mean in the context of COVID-19?
That's right, yes.
I think the only potential consideration that we have to keep in mind is if patients are receiving intravenous bisphosphonates that require going to a healthcare center to receive the medication. We do have to consider the possible risk of becoming exposed to the virus when we go to a center like that. So Ed, I think you had mentioned that at UCSF you are triaging patients based on clinical need for bisphosphonates. Did you want to share a little bit more about your decision making?
Sure. So a lot of that is based on timing. So if a patient needs the bisphosphonates, so for example, for osteoporosis, again, not in the fibrous dysplasia setting, if we can delay it for a couple of months, that's okay. And that would be part of the main reasons for the delay. I think in the medical centers, they are very aware of potential infection risks. So they are taking additional precautions for any patients that need to come in for their procedures.
Yeah, I completely agree with that. It's not, an urgent medication in general. Most of these infusions can be delayed for both to protect the patient from risks of catching the infection, and also to save resources for healthcare centers that are getting pretty strapped by trying to take care of a number of COVID-19 patients. So I think this is an area where most of the FDMAS community can try to be flexible.
Aquí repitiendo lo que dijeron los doctores, refiriendo a los bisfonatos intravenosos que uno necesita ir a centro médico, sería buena idea tratar de esperar de recibir las infusiones de bisfonatos, porque esta no es una medicina que sería emergente ahorita, especialmente porque si uno necesita estas infusiones necesitan ir a un centro médico y eso puede poner al paciente en riesgo a ser expuestos al coronavirus. Y también es muy importante recordar, porque si trata de esperar a no ir a recibir esta infusión, esto ayuda a guardar recursos para otros pacientes que pudieran usar estos recursos en los centros médicos.
I would emphasize that any types of medication changes should be discussed carefully with the patient's physicians so that the appropriate plan can be executed.
El doctor repite que es muy importante tratar de discutir cambios en medicinas con sus doctores para así tener un plan en qué pueden hacer.
One further medication question, this one about, I'm sorry, I'll probably butcher this, tocilizumab. Is that TOCILIZUMAB? Does that ring a bell? TOCI.
Can you spell it again? Sorry.
TOCILIZUMAB.
Mike, that's tocilizumab, the L6 inhibitor.
And they've read something about this medication being used on COVID-19 patients in China and Italy with good outcomes. And have there been clinical trials with FDMAS patients? Is there any research going about that in regards to interleukin 6?
So there has been conducted a small trial with that drug in France for patients with FDMAS. It was a blinded placebo-controlled study. The results haven't been published. We don't know the results of that. There is a report of a patient who got that drug and had a good response. In regard to its use in COVID in general, and I guess COVID in regard to FDMA, would be, I would say near impossible to say whether, how to judge whether it should or shouldn't be used. I agree with that. If you're on that medication, you're taking it, you should probably continue it. I don't know that I would go out to try and get on it, thinking that might be protective or helpful in this case. But those are my thoughts on that. Anyone else?
Repitiendo lo que dice el Dr. Collins sobre esta medicina, tocilizumab, what was that, what pronunciation?
Tocilizumab.
Tocilizumab. El Dr. Collins dijo que este estudio fue realizado en Francia sobre esta medicina, pero no sabemos los resultados de este estudio todavía. De medicina con el coronavirus, es casi imposible saber si esta medicina puede ser usada con este coronavirus. Si usted está tomando esta medicina, pues puede seguir tomándola, pero claro, siempre tratar de discutir esto con sus doctores.
We do also have a couple questions that I think you addressed a little bit in discussing FDMAS and COVID in general. With rib cage deformity and decreased pulmonary function, how would that compromise FD patients? And then I think related to that, would kyphosis or scoliosis, how would that affect patients in COVID-19?
I can talk about kyphosis and scoliosis. Basically, your scoliosis needs to exceed 60 degrees before it has any appreciable detrimental effect on lung function. And for the most part, we have tried to identify and treat patients before their scoliosis gets that bad. So unless you have significantly undertreated scoliosis, it's not likely that it will change anything with regard to COVID lung infection.
Yeah. Oh, sorry. Go ahead, Karen.
Okay. Thanks, Alison. El doctor Stanton dice que en relación de coronavirus con pacientes que tienen cifosis y escoliosis, hemos tratado de corregir esto antes de que sea muy severo. Pues, I think that was everything, yeah.
Yeah, I just wanted to add, I completely agree with Dr. Stanton, and the type of scoliosis that we would need to worry, or kyphosis that we need to worry about would be severe. So patients who have more mild to moderate scoliosis, I don't think need to worry that their lung disease is putting them at higher risk from a bad infection.
La doctora Boyce menciona que los pacientes que quizás están un poco más a riesgo de esto, serían pacientes que tienen cifosis severa. Los pacientes que tienen cifosis que es más moderada o no tan severa, quizás no tuvieran que preocuparse mucho por esto.
And then I think this is a question that is relevant on the community's mind at all times. And that is the status of research in FDMAS. But I think it actually is relevant during this time because I know that COVID-19, this current crisis, has changed research. And I'd love for you guys to speak to that.
Yeah, so, COVID-19's had a pretty detrimental effect on clinical research, at least temporarily right now, because any research that requires patients to go to healthcare centers or research facilities obviously can potentially increase their risk of being exposed to the infection. So at NIH, and I think at most major health centers, clinical research studies and clinical trials have been put on hold, with the exception of trials where the drug that the patients are receiving is truly life-saving. So, you know, at NIH, our natural history study is, you know, not currently seeing patients right now. We're still working, we're teleworking, so we're continuing to communicate with our patients and local clinicians, but, you know, coming to NIH to participate in any research is going to be on hold for a while. And it's also true of some of the translational laboratory research. You know, it's not safe right now to have a lot of people working in a laboratory because that's not consistent with social distancing. So a lot of those projects are on pause. But we are optimistic that although this pandemic won't last forever, I don't think anyone knows how long it's going to last right now, but we do know that it's not always going to be as bad as it is right now. So we are committed to, you know, getting back in gear and progressing our research as soon as we're able to do that safely.
I just wanted to add too that I have just been completely impressed and blown away at how fast COVID research is up and running and taking place, and studies are being done, and things are being discovered, and stuff is happening. A vaccine trial put in place in record time. Investigators from all across the world are collaborating with each other, regardless of, you know, getting any credit for it or claim. I mean, things are just moving so fast. I'm really impressed that the way research is stepping up. In the same vein too, I mean, I think there's also a lot of information flying around the web about this and that and different things, a lot of it not based on research. And I think it's just, you really only rely on, you know, reliable sources like the CDC or reputable publications. But, you know, our research for FDMAS is temporarily on hold. It'll come roaring back. The COVID research is really barreling forward. I think that we're going to come through this okay in the end.
Repitiendo lo que dijo la doctora Boyce, es que sí, las investigaciones clínicas sí están siendo afectadas por el coronavirus. Hemos parado a nuestros pacientes aquí en los Institutos Nacionales de Salud, ya no están viniendo por mientras. Esto es con la excepción de pacientes que están recibiendo medicina. Todavía esos estudios clínicos todavía están siguiendo. Pues también las investigaciones en los laboratorios ahorita están apagando porque pues serían muchas personas en un laboratorio y eso no es consistente con distancia social. Pero somos optimistas para que esto termine pronto y regresar a nuestras investigaciones clínicas pronto. El Dr. Collins menciona que él está impresionado en la colaboración mundial de diferentes médicos alrededor del mundo que están colaborando. Recuerda que es muy importante tratar de obtener información de fuentes seguras como de la CDC o fuentes así del gobierno y no recibir información de fuentes que no son muy seguras.
There is also a question about specifically the Italian doctors. You know, I know we have researchers there. We've shared a lot about their mice models, and there's a lot of concern for those. Has anybody heard from them?
No.
No.
All right, we certainly send our distribution out to our international community, and FDF will be sure to share more information for that. We do have another patient question. This is about white blood cells. If you have a high count along with having FD, would that be harder to fight the virus?
Sorry, could you repeat that, Tova?
Yeah, so if you have a high white blood cell along with having FD, would that make it harder for you to fight COVID-19?
So fibrous dysplasia typically shouldn't affect your white blood count levels. So I think the question would more relate to what is causing the high white blood count. I would expect that the fibrous dysplasia probably is not preventing you from being able to fight COVID-19.
Great.
I would agree with that too. I'm also watching the feed at the same time. And just to clarify, I think the question was actually also in the setting of asthma. I think the main aspect is that with asthma, that does change your risks of respiratory infections in general, as well as potential for complications. So that is probably the more important aspect with regards to making sure that prevention of exposure is maintained.
Dos puntos, comenzando con lo que dijo la doctora Boyce. Hubo una pregunta sobre glóbulos blancos y si los glóbulos blancos en presencia de displasia fibrosa, si esto afectaría la manera que uno puede pelear contra el coronavirus. Pues, eso no hay ninguna relación de fibrasia displasia sobre los glóbulos blancos. Sería más importante saber por qué estos glóbulos blancos están altos, pero displasia fibrosa no afecta. Lo que dijo el doctor Ed es sobre asma. Asma normalmente sí sube el riesgo de recibir una infección respiratoria, pero es
I'm muted. We'll just end with any final thoughts that each of you would like to leave the community with. Anything really you'd like to emphasize?
I think Ed did a great job of going over the major points that people should be taking home from the CDC recommendations, which is social distancing and how important it is, communicating with your care team. So I really think that's probably the most important thing that both people in the FDMAS community and general international community should be aware of.
And washing your hands.
Oh, yes, thank you.
Yes.
I think the other point that Ed made that I think is really important that occurred to me after the fact when I was talking about, some of the things going on the internet about trying that is, again, as he said, before you make anything, try and communicate with your doctor before starting medication, stopping medication, etc. The only other thing that occurred to me too is in regard to medications and potential inability to get them right now. It's possible that there are some patients with fibrous dysplasia who are on the drug denosumab or Prolia. But I think some people may be getting it in a sort of off-label use. This would be the drugs where stopping it abruptly, missing an infusion or even two, could be associated with some untoward side effects. So that would be one that, again, if your doctor is prescribing that medication, she or he should know that and do what they can to get you treated again with that. That was the one thought that occurred to me about that medication. Anything from Spain? Any questions from Spain? I know that we had families from Spain.
No, we haven't, but hopefully they've been appreciating the translation. Karen, I know that was a lot of information. I'd be able to briefly touch on what Alison said.
Oh, I couldn't hear you.
Are you able to sum up what Alison said and then also what Mike said? I know it was quite a bit of information.
Sure. La doctora Boyce, el doctor Ari, el doctor Collins, pues estaban repitiendo que tratar de seguir recomendaciones que estamos recibiendo en diferentes partes del mundo, como por ejemplo seguir lavándose las manos, estar en comunicación con doctores en casa. El doctor Collins mencionó que si uno está tomando medicinas así como la medicina denosumab, la medicina es muy importante estar en comunicación bien cerca con sus doctores por diferentes síntomas que pueden ocurrir o efectos secundarios. Eso creo que es los puntos más grandes que ellos acaban de repetir.
Thank you so much. Dr. Stanton, Dr. Hsiao, anything to add?
No, I think the CDC and the NIH spokespeople are giving us the information we need. There are many places in the United States that are seeing very, very few cases, but that's not going to continue. Just because things look rosy where you are right now, they may not be so rosy in about 3 weeks. So what we do now is going to affect what happens in 2.5 to 3 weeks from now. So if you've been told to stay home unless it's very critical that you have to go out, stay home. We need to save lives, and losing 100 or 200,000 in our country is a disaster that we want to minimize as much as possible. So pay attention to people that are making recommendations on science.
Doctor Stanton, enfocar el punto de que aunque quizás no hay muchos casos de coronavirus, quizás cerca de algunos de ustedes, es muy importante seguir estas guías que estamos recibiendo. Quizás en 3 semanas estos números de infecciones van a empeorar. 100,000 a 200,000 personas pueden perder sus vidas aquí en Estados Unidos. Pues nosotros tenemos que hacer todo lo que podemos hacer para tratar de mejorar esto y seguir recibiendo información sobre las personas en la ciencia, las personas médicas.
And I think it's also just important, again, to emphasize, take care of yourself, get enough sleep, take care of, your hand washing, and following those other recommendations as much as possible. And we hope that you stay healthy.
Esperamos que tengan buena salud. Es muy importante cuidarse de uno mismo, tratar de dormir suficiente, siempre lavarse las manos. Y cuidarse de uno mismo.
Excellent. Well, I want to thank all of you so much for giving your time and your expertise and your thoughts to this today. We're really grateful, and thank you to the community. We will be sharing this video in its entirety. Again, so sorry for the interruptions that did occur, and we'll be happy to share this video both on our Facebook and on our web page for afterwards. take care, stay safe, everyone, and have a great rest of your day.
Thank you.
Good job, Tova.
All right, great. Thanks so much, everyone. Have a great week. Stay safe.
Bye-bye.
You too.
So thanks for arranging this.